Hello, everybody. My name's Heather Henry. I am a nurse entrepreneur from Sale, Greater Manchester, and I run a community interest company, a social enterprise called Better Chance DIC, which helps children, families, and communities to learn about breathing in fun ways. This is probably the most serious thing I've done. And you're all very welcome. And with me tonight as our expert is Professor John Dickinson from the University of Kent. And I happen to know him because one of the early adopters of some of my crazy breathing antics is Medway Asthma Self-Help, which is a charity in Kent of which John is a trustee. And I spoke at their AGM a while back. And yeah, I thought I'd ask him to help with this. And to my right, probably somewhere else, you can see Jane Dennison. And Jane is a collaborator of mine in sales. She runs Mile Shy Club, which is a running club for people who are shy of running. And basically, this all came about because I had really bad asthma as a child. I should have shown you the picture of me coming last in the egg and spoon race. It had a big effect on my psyche. Various other terrible things happened to my lungs. And here I am right now at my ripe old age, trying to encourage people to who have asthma to know more about it and try to make our town, Sale, the country's first child asthma friendly town. So what I'm going to do without further ado, people are still joining, is to hand over to John. And he's got more than a few slides to run through. He's got some fascinating stuff. You might want to say some of them about your background as well, John, because I haven't done you justice at all. And hopefully we'll have some space for questions at the end, hopefully.
Yep.
Cool. You'll get sent the recording. If people can watch back, share the thing, and hopefully we'll make the world a happy place. Over to you.
Yeah. Brilliant. Thanks, everyone. Thanks everyone for coming along this evening and giving up a bit of your time to try and find out a little bit more about how we can maybe help people with asthma enjoy exercise and maybe get the most out of their exercise as well. I'm just going to share the technical bit of sharing my screen, and then I'll get into my introduction and get kicked through it. What I'm hoping to do, and I do get a bit excited about when I'm talking about asthma and exercise. I've aimed to basically do for about half an hour talk, so we've got plenty of time for questions and a chat afterwards is what I'm planning for. But I do sometimes get carried away, so apologies if I do run over that a little bit. My name's Professor John Dickinson. My kind of background is I'm a sports scientist by kind of training. But I've been involved in working with athletes with breathing problems since 2003. Is when I started doing my PhD in this area. But my PhD was all on sort of diagnosis and treatment of athletes with asthma. And that PhD was involved in working with the British Olympic team prior to the Athens 2004 Olympic Games. And then since then, I've kind of carved a bit of a niche in terms of sort of developing and delivering research that's all around helping athletes with breathing problems. And I've worked with, I say, the elite end. So I've worked with sort of a lot of football clubs. Worked with a lot of Olympic athletes. But at the same time, I also help a lot of recreational level athletes overcome respiratory issues, because at the end of the day, we're all human beings, and even though an elite athlete is performing at the highest level, they actually, what's going on with their respiratory system isn't any different to maybe a breathing problem that might be being faced at a recreational level. It's more just the level of sport that they're playing at, which is the difference. So that's kind of where I'm coming from. So hopefully within this talk, what I'm hoping to do is I'm going to try not to get too technical, because I'm sure I'm not talking to sort of a whole group of doctors or specialists in the area. So I'll try and keep it kind of as understandable as I can. But do ask me questions if I start going a bit too technical. But what I'm hoping to do is sort of touch on what asthma and exercise, and there's a condition that's like asthma. It's called exercise-induced bronchoconstriction. Sometimes we hear it called exercise-induced asthma. And they're kind of the same kind of thing, but I'll kind of talk about asthma and exercise-induced bronchoconstriction. They're treated in the same way. The real only difference between them is that people with asthma can experience exercise-induced bronchoconstriction, but it is possible that some people only experience the bronchoconstriction during exercise, and that's where this term EIB comes from. And again, they're going to talk about how asthma and the EIB might impact sports performance. We'll talk about strategies to help athletes optimize their asthma and EIB control, and I'll throw in a few sort of ideas that we've had when I've worked with elite athletes, but it's the same thing that I apply to non-elites as well. And then I'll also talk about other respiratory issues, because I find a lot of athletes that have been told that their breathing problem is asthma, and a lot of the time it's not asthma, and also as much of the time it's asthma and something else. So it's worthwhile not kind of putting people with asthma in a kind of, well, every time you're out of breath you've got asthma, or it's asthma that's causing that problem. So it's understanding what other issues can cause that breathlessness as well on during exercise, because that's going to help us support the person enjoy their exercise, and obviously and if they're enjoying their exercise and their breathing's not impacting their sport, then they're obviously going to perform better as well. So I'm just going to start with a video, and this might be something that a sort of a scenario you're quite familiar seeing. This is a runner that came to us, and she was complaining that when she was doing high intensity efforts, so if anyone's involved in athletics club, she's doing things like sets of sort of 4 or 5 400-meter efforts with a couple of minutes recovery between each one. But what she was finding was that she was struggling to complete those kind of 4 or 5 400-meter efforts, and it was all because of her breathing. So I'll just show you her to start off with, just so you can kind of see someone you might come across when you're sort of working with individuals exercising. If I press the right button, we will anyway. There we go.
Brilliant. You stand up for me. You stand up, just look straight, stand still and look straight ahead. Stay there, keep looking straight ahead.
So you can see she's in quite a lot of distress with her breathing. You can hear an inspiratory wheeze going on. You can see her kind of head's rocking backwards and forwards while she's sort of trying to get air into her lungs. And that kind of picture of an athlete is quite common for the athletes that I see through my clinics and in my research. But you know, she was complaining of a wheeze. She's complaining of a tight chest. She's complaining of a cough, and she's complaining of difficulty in breathing during exercise. And a lot of the time, my experience is that a lot of the time people go to their GPs, and unfortunately, some GPs will just kind of base not a solid diagnosis, but a sort of preliminary diagnosis, and say, well, it's asthma, and based on those symptoms, if they're confident that there's nothing else that can be causing it. The problem with doing that is that the symptoms are not specific to asthma. So we look at kind of what other issues can cause those symptoms. It's not just asthma. And so we see a lot of the time that, especially in mild to moderate asthma and exercise-induced bronchoconstriction, we see a lot of misdiagnosis when athletes or individuals who exercise aren't appropriately objectively tested for asthma. And just for an example of that, I'm not expecting you to sort of get the whole graph, but just as an example, we worked with Premier League and Championship level football players, and we needed to test them because back in 2009, every football player that was using a salbutamol, a blue inhaler, was required to provide evidence of their asthma. And a lot of the players using these blue inhalers hadn't actually had an objective test. They'd simply been given the inhalers based on their symptoms. And when we did our objective test, and we tested 65 players over the course of that year, and out of the 65 players we tested, only half of them could give us a positive test for asthma. So that would suggest that there's a high misdiagnosis rate, and because they hadn't been objectively tested, there were some players that were using inhalers inappropriately. So that's just one example out of elite football. And what can cause these sort of exercise respiratory symptoms? It could be a cardiovascular disorder, and there's pretty decent diagnostic procedures within the NHS that can help sort of rule that in or rule that out. So again, going through the GP and making sure that's ruled in or out is quite important. It could be physical limitation, so it could be simply someone hasn't engaged in much exercise, and then they suddenly start trying to do maybe a bit too much too early, and that can cause these types of respiratory symptoms. Obviously, it could be asthma or exercise-induced bronchoconstriction that's causing them. Could be an issue with their breathing pattern, and that's limiting how much air they can breathe per breath, and so therefore they struggle to get the air in and get those sensations. It could be an upper airway issue, and we see this term now emerging called exercise-induced laryngeal obstruction, and effectively that causes the upper airway to close in, and I'll show some more examples of that later on. Or it could be something more in the nasal passage that's linked to rhinitis that could cause it. So there's lots of issues that potentially might crop up that could cause those exercise respiratory symptoms. But I'm going to spend a bit of time just talking about asthma to start with, because obviously that's where we're coming from. And just if you're not kind of aware what asthma is, or an exercise-induced bronchoconstriction is kind of the same thing, but it's mainly that this kind of thing only happens during after exercise with exercise-induced bronchoconstriction. But if you think about asthma, what is asthma? When you hear people say, I've got asthma, what is it? And what asthma, the technical term about asthma is it's an obstructive airway disease. And what we mean by that is it doesn't limit the volume of air that you can put into your lungs or expel from your lungs. But what it does do is it impacts on the flow rate of the air when you breathe out. And so you can see if you look at these little these small airways called bronchioles in the lungs, and you can see the healthy bronchiole, the lining of the wall is relatively okay, and the smooth muscle which kind of wraps around these small airways is nice and relaxed. Now that allows air to pass through it without really much limitation at all. So an individual without asthma can breathe in and breathe out, relatively easy. Now, what happens in asthma, and this obstruction happens to varying degrees. So in asthma, when an individual hasn't been triggered off, their airways kind of look like a non-asthmatic's airways. But once they come in touch with an asthmatic trigger, be it dust, pollution, or it could be high ventilation rates from exercise, if that triggers off an inflammatory process that causes swelling of the airway wall and a release of inflammatory mediators. And those inflammatory mediators cause the smooth muscle around the airway to constrict. And so what that does is when someone tries to breathe air out, they're trying to breathe air through the smaller gap, and effectively that limits the speed the air can come out effectively. And so it's basically a limitation on expiration. But when you breathe in, the airway opens up because of the pressures that are created by the chest expanding. So inspiratory maneuvers aren't as limited as expiratory maneuvers for asthma. Now, the medication that an asthmatic might use, the prevention therapy will dampen down the inflammatory process. So look, the prevention therapy is there to try and reduce the inflammation, reduce the swelling of the airway wall. And the emergency medication, something like the salbutamol inhaler, that is simply there to relax the smooth muscle around the airway and hopefully open it up. Now, when we're talking about preventative therapy, we want to reduce the inflammation because the inflammation is what drives the condition, rather than simply just using medication that relaxes the smooth muscle around the airway. So ideally, if we're treating individuals with asthma, we're looking at prevention therapy, things like inhaled corticosteroids. It might be in combination with a long-acting beta-2 agonist, but we're looking at prevention therapy, and that's the same in athletes who might only experience the problem when they're actually exercising. But it's the same therapy we use with athletes as it is with a kind of an asthmatic that isn't an athlete. But just hopefully that paints a picture. When we talk about asthma, we're talking about the small airways in the lungs is effectively where that obstruction is taking place. Now, if we look at the prevalence of asthma or exercise-induced bronchoconstriction in kind of elite sport, you can see there's a varying prevalence depending on the sport. Now, I don't know if you know the prevalence of asthma in the UK, but the prevalence of asthma in the UK is somewhere around 9 to 12% of the UK population has an asthma diagnosis. So if you look at the prevalence of these sports, you can see that in the majority of cases, athletes are more likely to experience an asthmatic condition than a non-athlete. And you can see in some sports, so when we look at things like cycling, field hockey, rowing, swimming, football, they're more than double, if not triple, sometimes quadruple, sometimes even more when we look at the real high prevalence in swimming. So we see certain sports are more likely to have asthmatic athletes in them than others. And what kind of dictates that differentiates between why sports have different prevalences comes down to the exposure to the trigger. So we know obviously when you do sport, you breathe more, so you get an increase in the amount of air that's going in and out of your lungs. The other thing that changes is that when you start exercising, at some point you'll switch from nasal breathing to mouth breathing, and that's just natural because the gap the air's got to pass through in the mouth is bigger than the gap in the nose, and so therefore it's easier to pass larger volumes of air in and out through your mouth. So the reason why, but what that does is if you're doing more mouth breathing, it means that your lower airways have to condition the air. And so what happens in the nose, when you breathe through your nose, the air gets warmed, humidified, and filtered. So by the time it reaches your lower airways, by the time the air gets into your lungs, it's nicely conditioned for gas transfer. But if you're breathing through your mouth, it means that all your lower airways have to do all that warming, humidifying, and filtering of the air. And so therefore your airways are more likely to dry out, and then you get an inflammatory process on the back of that. So in increased minute ventilation, so sports that have a higher ventilation. So if we go back to that figure, you'll see that the sports with much higher prevalence of asthma and exercise-induced bronchoconstriction than the general population are generally high ventilation, sustained high ventilation sports. If we look at other triggers, if we then add on dry air, or you add on particulates like pollution or trichloramine, which you find in the swimming pool, into that as well, you then add in another trigger. And again, so you add the trigger, you increase the exposure, you increase the likelihood of a development of an asthmatic issue. And so we see the sports that are the high ventilation sports, the sports that take place in environments with kind of high number of asthma triggers like dry air or pollution, they tend to be the sports with the higher prevalence of the asthma. So as much as it is, as much as we can do, we try and advise athletes not to compete or train in kind of times of high pollution or in dry air. But some sports you can't avoid that. So if you're a cross-country skier, you can't not train in cold, dry environments. Same thing with if you're a football player and it might be pollen that triggers you off. You can't not play football in March and April because the football season is going on. So in some environments, we have to manage the athlete to allow them to train in that environment, because we can't change the environment. So we just have to be aware of that when we're working with our athletes. I'm not going to spend too much time on this slide, but there's plenty. Basically, what this slide I'm trying to make sure is that basically, if an athlete gets told they've got asthma, make sure they've had some sort of objective assessment to back up that diagnosis. So they're not just using the symptoms as the basis of the diagnosis. So we need to have objective assessments to basically either demonstrate that an athlete has an airway reversibility. By that, what we mean is that their lung function improves after they've taken an inhaler like a salbutamol inhaler, or they've demonstrated that if they measure their lung function at rest and then they go and exercise and measure their lung function again, that there's a drop off in their lung function, and then that lung function returns after they've taken their inhaler. So we need some sort of objective test to demonstrate that the individual has asthma to confirm it, rather than simply going off symptoms. And then once we've diagnosed it, we can there's lots of different types of inhalers that can be used. And what we really recommend is that everyone uses some form of inhaled corticosteroid, which is typically these brown inhalers, because that works on the inflammation. The inflammation is the cause of the issue. So we want to dampen down that inflammation as much as we can. And then they might be, if they've got a mild form of asthma or exercise-induced bronchoconstriction, it might be just using a ventilator inhaler when required, but we're not asking them to rely on that ventilator inhaler to get them through their exercise session. But if they got maybe moderate or severe exercise-induced bronchoconstriction or asthma, then they're likely to be on some sort of combination therapy, which is a bit of a mix of corticosteroid and the medication that relaxes the smooth muscle. And then there's also other bits you can add on. But what's important is that the medication is adhered to, the therapy is used as prescribed. A lot of athletes tend to use their inhaler for a couple of weeks and then feel that their lung function feels better, so they stop using their inhaler. And it's the same kind of story in just management of asthma. But the asthma management of an athlete isn't any different to the management of an asthma patient. It's just, it might be that the asthmatic athlete might not be asthmatic at rest as a usual asthma patient, but because they're exercising regularly, they still need to make sure that they use their preventative therapy on a regular basis rather than just simply relying on a salbutamol inhaler to get them through a training session. So that's maybe a warning sign. If you've got an athlete that are simply just keep running to the side of the track or coming off the pitch to take their inhaler, that could be a sign that their asthma is not particularly well controlled, or it could be a sign that maybe they've got another issue as well as asthma that's causing that their breathing issue. And what impact does that have on athletes if we actually get them on the right inhaler therapy? What effectively it does is it allows them to improve, well, one, it improves their lung health so that they haven't got as much inflammation, but also keeps their airways open. And if their airways are open, it means they can ventilate more per minute. And that obviously means that they can deliver more oxygen to their working muscles. And effectively, they can just perform more. So we see evidence that basically asthmatics on and off therapy, there's a dramatic improvement in their exercise performance whilst they're using their therapy as prescribed. And some of the work we've done within elite football, again, we've screened sort of players from the Premier League, the Championship, and League One. We found out of the 97 players we tested, 29% of them gave us a positive test for asthma or for exercise-induced bronchoconstriction. And then when we treated them, we saw reductions in airway inflammation measured by exhaled nitric oxide, and we saw reductions in their asthma severity. And what we also saw is an improvement in their VO2 peak to that. So the asthmatic athletes that weren't using inhalers to start with had a VO2 peak less than their non-asthmatic counterparts, which basically means that their aerobic fitness wasn't as good. And then after they'd taken their inhalers for a 6-week period, their aerobic fitness improved to that of their non-asthmatic counterparts. And what it basically demonstrated was the inhalers improved the football players' lung health, and that then had a knock-on effect to improve their aerobic performance as if they didn't have asthma. And that's just exactly an example of why it's really important to treat appropriately. And so, I'm rattling through this, and I apologise if I am, but hopefully you can come back to some of that with questions. But another, just wanted to sort of go through a few lessons of good practice in terms of managing an asthmatic athlete, because since 2013, I've been involved in supporting the GB swimming team manage their athletes for respiratory issues. And as you saw in the prevalence, asthma is a highly prevalent in swimmers. And so when we were working with this team, we actually found prior to the Rio Olympic Games that 70% of the British swimming team had an asthmatic issue. So that's obviously a ridiculously high prevalence, and the part of that is caused to the ventilation that they're required to do. So they train 5 hours a day, 6 days a week in the pool, and also they're all training in indoor pools. And in indoor pools, there is a higher level of what's called trichloramine, which is basically what chlorine turns into when it's cleaning dirt in the pool, and that turns into a heavy gas. It kind of sits just on top of the pool, and it's not a problem for recreational swimmers, but if you're spending a lot of time in these indoor pools, you're breathing in a lot of trichloramine, and that's likely to irritate your airways to the point where you might actually develop an asthmatic issue over time. And that's why we see such a high prevalence in swimming. But that's kind of we can't really change the training environment, can't change the pool environment very quickly. But if we appropriately manage these athletes, then we can make sure that their lung health is as healthy as it can be, and so that means that they can perform as well as they can do as well. So certain things we did, some of these things were really simple. First thing we did was actually just simply check their inhaler technique. So one of the things I've noticed over time of working with athletes, a lot of time they come to see me for a test, and I help do the diagnosis part. And then we say, yeah, it's like asthma. They go to the doctor. The doctor will give them some inhalers. They might get told how to use that inhaler, and then they just kind of be on their way. And there wouldn't be much follow up. But what we did with the swimmers was we actually checked their inhaler technique after a period of the time of them using their inhaler. And you might think, well, it's not that difficult to use an inhaler, but if the technique's not right, then you're not getting the right delivery of medication to your lungs. So if we look at the kind of the steps for a good inhaler technique, all the swimmers pretty much had a decent inhaler technique, apart from this one here, where basically inhale slowly. When we're talking about inhale slowly, we generally ask individuals using what's called a metered dose inhaler. So the ones that are a bit more of a spray type inhaler, like this Ventolin inhaler here, the optimal dose to inhale this is about 30 litres per minute, which is actually a really slow, deep inhalation. When we asked the British swimming team to demonstrate, or the ones using inhalers to demonstrate the speed that they would use their inhaler at, we got an inhalation rate of 324 litres per minute. So these athletes were taking really fast, aggressive breaths into this inhaler. Now, what the problem is if that happens is it basically a lot of this therapy that they're inhaling in just gets stuck to the back of their throat, and then they swallow it into their gut rather than it getting inhaled into their lungs. So the therapy becomes a lot less effective, basically. So the solution was simply to make sure that every swimmer used a small pocket chamber. And what there's two advantages to this is, one, that when they squirt the inhaler, the medication sits in the pocket chamber. And two, when they breathe in, the pocket chamber's got a whistle on it. So they hear the whistle, that means they're breathing too fast, and they simply get that audible sense to basically slow down the breathing rate, and then we optimize the delivery of the medication to the lungs. So that's a simple thing to stop athletes overusing therapy, and also making sure that their lung health has got the best chance of being optimized. Second thing we did was actually just check their inflammation. So we can do things like measuring exhaled nitric oxide, which is a really simple test. We simply just get someone to breathe out into a little device. It looks like a bit of a breathalyzer, and it measures their nitric oxide. And why that's important is because in some types of asthma, a rise in nitric oxide basically in your exhaled breath demonstrates you have a high level of inflammation. And so we can basically look at the impact of that inflammation over time, pre and post using the inhalers, which is really effective. Another simple thing we did was just simply retest the athletes when they were using their therapy. So one of the athletes, we measure their lung function, and then basically after our provocative test, we basically simulated breathing during swimming. And before the diagnosis, their lung function dropped off 38%, which is kind of quite a moderate severe drop off in lung function. And then after we've been using their inhalers for 3 months in this case, their drop off in lung function was 7%, which is what you'd expect a kind of non-asthmatic individuals to have to the test we did. So we can be confident the inhalers are doing what they should be doing. And that means that when an athlete's in the pool now, and maybe if they're still reporting breathing problems, but we're confident their asthma is well controlled, we don't go use more asthma therapy because that's well controlled. We might then look at other issues that might be causing that issue. And then I'm just going to spend 5 minutes talking about the connected bits, because what we also did with the swimmers was we asked them, we did more of a systematic review of their respiratory issues. And what we found with every swimmer in the group going to the Rio Olympic Games was that every swimmer that had an asthmatic issue also had another issue linked to their respiratory system. So that could have been a laryngeal closure, could have been an issue with nasal disease or abnormal breathing sensation and things. So we knew that this really identified to us that it's not just as simple as diagnosing an athlete with asthma and then just treating the symptoms with asthma, because that's not particularly offering the athlete an optimized or not going to optimize the management of that athlete. And so therefore we may end up giving them more medication than they needed, and they still don't feel that their respiratory symptoms are totally managed. So we need to make sure we're systematically looking at what's going on. And in a recent study by the English Institute of Sport that I was involved in, we've systematically put athletes involved in sports that are getting ready for this Olympic Games coming up. And we tested 122 athletes. And what we found was that 97 of those athletes had at least one respiratory issue. And you can see from the prevalence here that nasal issues were the most prevalent, followed by allergy, followed by laryngeal obstruction. And then you got asthma here. So about 22% of the athletes had an asthmatic issue. And then also 22% of the athletes also had a dysfunctional breathing pattern potential issue as well. So 80% of the athletes had one condition, but we also found that 60% of the athletes had two respiratory issues. And we started to notice that there were kind of clusters of these issues. So asthma seemed to be clustered with allergies and nasal issues, and laryngeal obstruction seemed to be clustered with dysfunctional breathing pattern. But we also found athletes that had asthma and had dysfunctional breathing pattern or laryngeal obstruction. And so we developed this kind of nice heat map. But it just goes to show that the athletes are regularly going to experience respiratory symptoms. And yes, asthma might be one of those respiratory symptoms, but there are lots of other issues that might also happen instead of it being asthma or as well as it being asthma. And that's why it's important to understand that as well. So I'm just going to sort of talk through an issue that might get diagnosed as asthma, but might not be the case. And that's a dysfunctional breathing pattern. And it's a lot of the time I come across athletes that sometimes have asthma, but they've also got a dysfunctional breathing pattern, but the breathing pattern hasn't been managed, or they're not getting any therapy for it. And sometimes they haven't got asthma at all, and it's only their dysfunctional breathing pattern which is what's causing the issue. And the reason why you get a lot of this misdiagnosis is because the symptoms between the asthma or exercise-induced bronchoconstriction and dysfunctional breathing patterns are very similar. So they both report tight chest, they both might report wheezing, sometimes they might report dizziness or mucus production, cough, shortness of breath, but there are subtleties in when those symptoms occur. And so with appropriate questioning, we can tease out a little bit what it might be. But again, just with this questioning, that doesn't necessarily get to the bottom of it. Because I mean, recently I was testing a cyclist that was giving me very similar symptoms to dysfunctional breathing, and I thought it was going to be a dysfunctional breathing issue. But I made sure I did the test for asthma initially, and basically I measured his lung function before he got on his bike. And then about 10 minutes after he'd done some hard cycling for me, and he got symptomatic, and then I measured his lung function afterwards, and his lung function had dropped off 50%. And it was basically, he had quite a severe exercise-induced asthma issue. And so initially it was a case of actually working through the therapy with him. So that objective testing for asthma is really important, because off these symptoms alone, we can't say one way or another, even if we know a little bit more about the symptoms. And the kind of consequences for dysfunctional breathing patterns, what we tend to see is dysfunctional breathing patterns tend to really impact breathing during really high intense exercise, whereas asthmatics can actually get through the high intensity exercise, and then it's after the high intensity exercise when the bronchoconstriction kind of takes place. So that a lot of the time when we see individuals with a dysfunctional breathing pattern, they really reporting difficulty in breathing, and it's usually breathing in, and it's usually during high intensity exercise. And they usually have a real high, they basically say their breathing is what is the limiting factor to their exercise capabilities. They feel that they can't take a satisfying breath in. We sometimes see a lot of over recruitment of respiratory muscles like the shoulders, and possibly too much movement in the abdomen to try and move that rib cage. And a lot of the time, sometimes their breathing pattern gets that bad, they develop a laryngeal obstruction as well. And there's different types of dysfunctional breathing pattern, but I'm not going to get into that because I'm starting to run out of time. But I'm just going to go through just to demonstrate to you some of the things that we're doing in the lab to try and identify this. So we're using a system where we're using 3D motion capture to try and objectify what a good breathing pattern is, because you know, I don't think anyone's ever taught anyone how to breathe properly. And yes, there's advice about what a good breath is, but to objectify a good breathing pattern, no one's ever done it before. And so some of the work we've recently done is basically use this 3D motion capture system to look at the movement of the rib cage at rest and during exercise to kind of quantify what a good breath is. And once we've got this 3D motion capture, we can basically segment all the different parts of the torso. So we can look at chest versus abdomen. And when we do that with a healthy breather, we look at, this is basically a graph that shows rib cage movement and against abdomen movement. And when we're moving left to right on the graph, we're breathing in. And when we're moving right to left, we're breathing out. And you can see with a healthy breather, the abdomen and rib cage all move together on the way in, and they all move together on the way out. And so we've looked at athletes that have no breathing symptoms and no history of asthma. And we've looked at athletes that have a history of asthma and experiencing breathing symptoms during high intensity exercise. And we looked at individuals that just have an asthmatic issue. And we've kind of put them through their paces. So this is just an example of what we've been doing. So we can get in the cycle and we look at tracking their breathing pattern during exercise. And you can see the kind of data capture.
Good, keep pushing it.
And then what we can generate from that are these kind of real-time images of breathing pattern. And we can see kind of the breath going in and out. And this is an individual who's exercising high intensity, but you can see that they've got the pattern of a good breather. Their abdomen and rib cage are moving nice and smoothly on the way in and nice and smoothly on the way out. And so we compared that against people with asthma and against people that maybe have a dysfunctional breathing pattern. And what we can see, this is an individual with exercise-induced asthma at rest, and they're not obstructed at this point. And so you can see their breathing pattern's actually looking pretty healthy. And when we've actually induced an asthmatic response on them, their breathing pattern changes. So you can see this is the breathing pattern of someone who is experiencing an asthmatic issue. You can see that instead of going their abdomen and ribcage moving together, in this case, the abdomen's moving first, then the ribcage is going up, and then the ribcage is moving as they breathe out, and then their abdomen moves. So we lose that synchronicity between the two, and that lack of synchronicity then impacts how much air they can actually ventilate their airways with, because it impacts the movement of the ribcage. And then once they've actually taken their inhaler, so their airways are now, so the small airways are opened up again, their breathing pattern reverts back to more of a normal, healthy breathing pattern. And then when we look at a dysfunctional breathing pattern, we see this individual's reporting difficulty breathing during high intensity training. And you can see even at rest, their breathing pattern isn't what we kind of might deem healthy, because their abdomen and rib cage aren't moving together. In this case, the abdomen's moving first, then the rib cage moves when they breathe in, and then when they breathe out, the abdomen moves, and then the rib cage moves. So it's not in sync. It's not in sync. And then when they're exercising, that just gets exacerbated. And the consequence of these inappropriate movements, or the lack of synchronicity in the movement, means that again they're not allowing their rib cage to expand appropriately, and then that impacts how much air they can get in. It also means that they're likely to breathe at a higher flow rate of air, so there's a lot more stress going through the upper airway, which might cause a laryngeal obstruction as well. And so you can just kind of see all those different types of breathing pattern together, and there's different types of dysfunctional breathing patterns that we've seen. So you can see again, there's different forms of dysfunctional breathing, and that all of our understanding of that now allows us to specifically give breathing pattern training for athletes. And that breathing pattern training needs to be delivered by someone who kind of knows what a good breathing pattern is, but we're hoping to make this more accessible, so coaches can identify athletes that maybe can improve their breathing pattern and their breathing technique. And the reason for that, it's quite complex why an individual might have a dysfunctional breathing pattern, because it could be down to technique, it could be down to postural control, could be down to sort of anxiety, stress issues, it could be down to some form of inspirational muscle weakness. So there's lots of reasons why an athlete might experience that. But once we've identified that that's the issue with the athlete, we can be quite a quick effect. So just go back to that athlete that I showed at the start, and you see, you'll start to see that this actual problem wasn't.
You stand up, just look straight, stand still and look straight ahead.
Functional breathing pattern. So you can see her stomach and her chest aren't moving together.
Stay there, keep looking straight ahead.
Is an inspiratory wheeze rather than expiratory wheeze, and her shoulders are disappearing up. She's not getting much lateral movement in her rib cage. So we identified that with her and did two months worth of breathing pattern training with her, and this is the kind of change we got.
That's it. Cool. Can you just stand up for us? Just look dead straight forward. You just pull your shirt tight.
Your head's not wobbling backwards and forwards. There's no wheeze that she's got when she breathes in. Better the abdomen and rib cage are moving better together. And we've got much better sort of lateral movement, sideways movement of the rib cage. And her breathing frequency is less. She's breathing less times per minute. And so that was, we can be quite effective with basically making sure we get the right diagnosis for the respiratory issue. So just to summarize, I know I've probably gone a bit more than half an hour there. Sorry, told you I might get carried away. Hopefully still got time for questions. So just to summarize, it's really important to get appropriate diagnosis and then appropriate manage asthma or exercise-induced asthma. And when we do that, that will allow individuals to successfully engage in all types of sport. I've not had the situation yet where I've come across an individual where I've had to say you can't do sport because of asthma. Optimizing asthma management, so making sure we're on the right prevention therapy, improves lung health, and then that ultimately, because we've improved lung health, will improve exercise performance and actually enjoyment of exercise. And a lot of the time, I've talked a lot about working with elites out there, and a lot of the time, I think a lot of people get turned off of taking part in sport because of their fear of becoming breathless. And so it also improving their lung health is going to improve their enjoyment of sport as well. Where possible, if it's possible to exercise away from asthma triggers, do it. So for example, we think about the summertime now, the time that air pollution is at its greatest is kind of late afternoon. And so maybe exercising in the morning or in the evening once it's a bit cooler is a good time to exercise for an asthmatic. Obviously, exercise away from busy roads and those sort of things is really important as well. And also consider kind of a comorbidity or a condition might also be occurring as well as asthma. And if we're confident that asthma is well controlled, but the athlete's still experiencing respiratory symptoms due to high intensity exercise, you might want to consider that they also might have an issue such as dysfunctional breathing pattern, or it could be rhinitis, or it could be laryngeal obstruction, rather than simply badgering them that your asthma is so bad that that's what's limiting your performance during training. And we know that appropriate breathing pattern training can have a really significant impact on athletes who are experiencing respiratory symptoms during high intensity exercise. And then just last plug, if anyone's really interested in it and wants to find out a lot more, there's a book on it as well that we've recently published. So if you wanted to sort of read up more in depthly on this, if you go to kind of the complete guide to respiratory care for athletes, you can get it off Amazon or whatever. Then you can read much more in depth about kind of the processes and how we manage or how we recommend that athletes with respiratory issues that are managed, and that includes asthma and all the other issues that I've talked about as well. So I told you I'd go more than half an hour, but I'll stop there. I'm quite happy to sort of have a little chat about all the things we've raised. If anyone's got any specific questions about what I've been talking about, feel free to fire some questions off.
Wow, thank you so much. And that is why I invited him, ladies and gentlemen. So now it's over to you. So if you want to speak, either put your electronic hand up or your personal hand up, and I'll come to you. Yeah. So I wanted to ask a question first, if I might, which is about, you've not talked about the benefits of exercise to people with asthma, something that I discovered very late in life. Yeah.
Well, yeah, I mean, basically the benefits of exercise for people with asthma are multifactorial, I think. I mean, obviously you've got the general benefits of exercise will improve your fitness. That will improve your health status. So you'll get those things. But what we actually also see with asthmatics who exercise, it can be a really powerful tool as part of the management process. Because what we actually see, as you get fitter, it actually helps to reduce the inflammatory amount of inflammation inside your airway. So then that obviously improves your asthma status. It also helps helps you improve your breathing control as well. So you sort of learn to control your breath better. So it does mean if you do experience an asthmatic exacerbation, you're more likely to be able to kind of control it and not let it exacerbate so much that you need to call the ambulance or become hospitalized. So there's lots of benefits for individuals with any level of asthma to engage in exercise. I think the key is if an asthmatic hasn't really engaged in exercise and they're coming into it, the key is not to just jump in and think that you're going to get to the Olympics in 2 years' time. It's to kind of start slowly and just gradually increase that intensity and become comfortable in it and enjoy it, and kind of work within your kind of comfort zone within your respiratory symptoms initially, making sure you're on the right inhalers and things. And then, then once you've kind of done that introduction to kind of get yourself into exercise, then you can start to push it a little bit more. And it's just making sure that you have regular appointments with asthma nurses and GPs to make sure that if you do start to up that exercise intensity, it might be that you might just need to modify your inhaler therapy to make sure that you're appropriately protected.
Yes. Yeah, absolutely. I mean, at one point I thought my asthma was getting worse, and actually I discovered that, frankly, I was unfit. But because I know that we have at least one parent of a child with asthma here who's having trouble with sport. So if you do want to ask any questions about that, then do please jump in. Any questions? Because that was a lot of information, and I'm glad we recorded it. Sue, go for it.
Yes, I can't find my electronic hand. Apologies.
Physical ones are just as well, or in the chat. Feel free, whichever way you fancy.
Bless you. No, thanks, John. Thanks for that overview. Really, really helpful. I just wanted to ask about accessing the objective testing, and is that readily through the GP practices, and are they happy? If you've got a diagnosis of asthma, but that's just from symptoms, and you said obviously it needs more exploration. Are there things that people can do, because obviously you can get a lot of gadgets at home that help, that people can find things out from? What's the best way if they're facing some barriers, really?
Yeah, I mean, I think this is the reason why we get a lot of misdiagnosis, because I think a lot of GPs either don't have access to the right, or don't know where to send the patients effectively, or even ask for the right kind of assessment. And so, I mean, basically, really, most GP practices won't offer the objective assessment within the GP practice, and it will require a referral to a respiratory consultant within a hospital somewhere to get a test. And then it's a bit of a hit and miss as to whether that hospital offers an exercise specific type protocol for the diagnosis, or will offer more of an assessment of just more allergic asthma, if you like, that might be more looking at resting breathing pattern, resting breathing. So it's a little bit about doing homework. I know, for example, you're quite lucky in Manchester. There is, I think it's the Wythenshawe Hospital has got a pretty good respiratory unit there. There is also, if it's more of a exercise specific case, there is a Manchester Institute of Sport and Health or something. I think that's what it's called. But there is a Manchester sort of based clinic that really specialises in exercise induced respiratory symptoms, that you could potentially get them to refer you to there as well. So in Manchester there are some options for it.
I know in Salford it was a trial, and I don't know whether it was further funded, was primary care diagnostic pheno testing, and they'd got spirometry as well. So obviously that was an option for the practices to be able to refer through, which is really good to see. But you need longer term funding, don't we, for things like that?
Yeah.
Thank you.
Yeah, and I think, I mean, the pheno stuff is great, but a lot of the time, like I say, a lot of GP practices haven't got it. It's part of the kind of nice guidelines to include it, but it's just, again, it's hit and miss as whether your GP has that or not.
Yeah, I think.
No, sorry.
I was going to say, as a former practice nurse and of that clan, I listen to them a lot. They're saying that spirometry is usually more. That's where you exhale into a machine, and it, for those of you who don't know, and it measures how hard you can exhale. And then, so I think that's slightly more prevalent than pheno testing, where I think the machine's still quite expensive. And some of the disposable products that go with it are quite expensive as well. So I think it is a complete lottery, as you say. And I'm guessing that there's no benefit really in peak flows, which is the most common objective test, because it's
it's interesting. I mean, peak flow, I mean, as a diagnosis tool, especially within kind of the realms of asthma and exercise, it's not particularly helpful at all. So yeah, to kind of get fobbed off with well, we'll do a resting peak flow and then decide that based on your symptoms it's asthma is a pretty poor level of objective sort of investigation. Really, it needs to be a full sort of a spirometry investigation at worst, really. But a lot of the time we see individuals that really only have the problem during exercise.
Yes, that's the point. When you get to GP surgery, they're at rest. Although I've seen respiratory consultants make children run up and down stairs and then do their spirometry. Yes. Yeah, we're talking in the chat there about getting the message out to schools and PE teachers. I'd love to do that in Sale, but they're so busy at the moment. I was just talking to John before about talking to Manchester FA. If you're working in Greater Manchester, then and you're interested in that, do keep in touch with me. Nikki's saying that there's quite a few specialist centres. Jane, I know you have to go or has gone, but thank you for joining me. And multidisciplinary team, Nikki. Yeah, absolutely. And a reminder really that physiotherapists are quite often trained in breathing pattern disorders or dysfunctional, dysregulated, that's the correct phrase, isn't it, physiotherapist? Dysregulated breathing patterns. It's a very specialist area, absolutely. The best option is a referral to a multidisciplinary team. Yes, that's yeah, and for physiotherapists to unpick what's happening again. And I don't know from you physiotherapists, is it a common part of your training to address this, or is it something that you pick up post registration? Can you tell me? No, it's not. Yeah, thanks, Felicity. I had a feeling that was the case. So again, it might be a lottery as to whether your GP can refer you if they notice breathing pattern disorder and that test that I can't pronounce, the Niemann questionnaire.
But I think one of the problems for dysfunctional breathing pattern within exercise, there isn't a standardized kind of questionnaire or thing like the Nijmegen thing that you can use it. There's also a breathing pattern assessment tool as well that can, but again, all that's done at rest and it doesn't really look at exercise. And that's basically the reason why I got into the dysfunctional breathing pattern stuff as well, because when I was at the British Olympic Association, I was picking up a lot of athletes that said they had asthma and didn't realize, and they didn't. And then we returned to the physios, and I went to the physio, what would you recommend? And bit like kind of Felicity said there, a lot of the physios that are working in sport are musculoskeletal experts, not respiratory experts. And so they kind of said, well, we did a tiny bit during the training, but that was pretty much it. And so basically they it wasn't a medical, there's no medicine to use and there was no physiotherapy support. And so I was kind of basically said, well, come up with something for them, and to kind of help these athletes overcome their breathing pattern. That's kind of where I got into it kind of about 18 years ago, sort of developing strategies to help athletes overcome dysfunctional breathing patterns.
Yes, big one.
But like you said, I mean, I think it's coming quite a lot in the chat, is that it's really important to get this awareness of the dysfunctional breathing pattern as well as the asthma, but then also to what do you do with it once you know someone's got it? How do you help someone overcome it? And that is, like I say, it's a multifactorial thing.
Tell me about it. Diane, come on in.
Yeah, sorry, I just could add a little bit more particularly about the triggers for exercise-induced laryngeal obstruction, because I think I probably have that. That's a personal thing. I've been through the process of telling my GP that I get a sort of shorter breath and have an inspiratory stridor. Because I'm a nurse, I would tell him that. And because of my age, because I'm 66, I had this investigated about when I was 60. They did a myocardial perfusion scan to make sure there was nothing wrong with my heart. And then they did some respiratory stuff. And eventually I was told that I needed to lose weight, which is one of the reasons why I was trying to exercise. So vicious circle, shall we say. But I know, because I'm now lifting weights regularly. I train with a trainer 3 times a week lifting weights. And it's when my heart rate goes up past about 155 that this thing happens, whatever it is. And I know that I don't have to actually stop. I just have to reduce the intensity, carry on. And after about 30 seconds, I'm fine. But I'm inspired by this talk to actually go and get a proper diagnosis, let me put it that way. But interesting, what are the triggers that you would find in sports people?
Well, yeah. So what tricks? Sometimes anxiety, but a lot of the time it's to do with the flow rate.
Yeah.
So it's interesting. You see a lot of time you see it with athletes when they, like you talked about there, about your heart rate going above a certain number, like I think it was at 150 or whatever.
Yeah.
But that would obviously be the point when you start to exercise hard. Now, if the breathing pattern isn't as great, that can cause a faster flow rate through the upper airway. And effectively, what happens is, if you think about the sort of the point just on top where your trachea is, you got your larynx sits. Now, if you're breathing in fast, what that can do is that the airflow going through the middle of it basically can cause it to sort of fold in, and that's where you get that laryngeal obstruction. So a lot of the time, it's not actually a kind of an environmental trigger. A lot of the time, it's just simply the speed the air's going through the airway. The other things that can cause it, you can have kind of almost, I call it a floppy larynx, in terms of the structure is just a little bit not conditioned as well, and just kind of a fold in at a given flow rate as well. We do see sometimes certain environments do trigger it, but a lot of the time it's more, most of the time it's more just simply the flow of the air going in and out. And it, like I say, as soon as you kind of back off the exercise intensity, it goes away. And a lot of the time, the management of it is really looking at breathing pattern and trying to breathe so you're able to still get a deep, strong breath in, but the flow rate's not as fast through the upper airway. So therefore, the structures don't collapse.
I did see a speech therapist privately, because that's basically where the problem might be, shall we say. And the simple techniques are yawning with your mouth closed, sniffing, and taking sips of water. And interestingly, if I take a mouthful of water and just hold that in my mouth, the stridor stops immediately, and and I'm fine. Really interesting.
Yeah, and I mean, there's different techniques, because a lot, like say, a lot of it's flow. So I mean, breathing through the nose can be beneficial as well, because that kind of slows the flow down. But and you can mess up. There are some techniques you can play about with your tongue, and by sticking your tongue to the top of your mouth and almost kind of interrupting the flow before it gets to the back of your the air gets to the back of your throat and things. There's a few little things you can play around with, but a lot of the time it's difficult to say exactly what's causing it without obviously sort of looking at you. But there is again, honestly, I should really remember these names, but the Manchester Institute, I think of sport and health and performance or something like that, they do specific investigations into laryngeal obstruction and exercise-induced laryngeal obstruction. So it might be worthwhile just looking them up and seeing if they'd be happy to stick a camera up your nose to look at your larynx during exercise.
Lovely, thank you. Thank you.
Okay, have we got some more questions? There was a point made about breathing pattern disorder being more prevalent in post-COVID, long COVID. Sarah, did you want to have a question?
Yeah, I just wanted to, I'm the one with the daughter who plays football 4 times a week, and was getting quite out of breath when she was running up and down on the wing. Goes to the doctors, given an inhaler. So she's got both blue and brown inhalers. What's a reasonable length of time to see if it's working? Because she'll probably confess that she doesn't probably use it as frequently as she needs to. So I'm thinking, is there like, we should say, right, for the next 6-8 weeks, she should use the brown as she should, and then get her reassessed, because she's not had an assessment. They've just given her the inhalers and said, oh, you sound like you've got exercise-induced asthma.
Yeah. What I'd probably say is it takes about, for the brown inhaler, it takes about 2 weeks for it to build up into your system. So it'll take about 2 weeks, but it's probably worthwhile leaving it sort of 3-4 weeks to actually kind of see what the effect is. The blue inhaler, though, will work within sort of 30 seconds of taking it. So you can kind of judge the impact of both inhalers in a different way. So if she takes the blue inhaler before she plays, and then she still feels breathless, that might give you an indication whether it's asthma that's causing that issue in the first place. But you probably want to give that brown inhaler a good 3-4 weeks of use on as prescribed, so like morning, night, as they prescribed it, to really kind of see if that reduces the need to take a blue inhaler. But what you want to, she shouldn't be kind of running off every kind of 10-15 minutes to try and take a puff of the blue inhaler, because basically the blue inhaler, it works quite quickly and it lasts about 4 hours. So it should be a case of take that blue inhaler before she goes, and unless she's got really severe asthma, which it doesn't sound like she has, because it kind of she can play football enough. That should probably be enough to protect her during a session, but it's just not the most optimal treatment by using it by itself.
Okay.
I think
makes sense.
I think John's
Yeah, no,
from a nursing from a nursing perspective, I'd say you know, ensuring they get the preventer down them twice a day, every day, even when they're well. But the other thing John mentioned was the inhaler technique. So actually looking at the inhaler techniques on, there's an app called Right Breathe, Sarah, that you can download, and it has every type of inhaler. There are 116 last count types of inhaler. So I'm presuming that she's just on a
yeah.
one of these. Yeah. Okay. So that and Asthma UK, they've got really good videos. So as John said, there's only 1 out of 10 people and 2 out of 10 nurses can use an inhaler correctly. First time. And the use of a spacer, if she hasn't got a spacer, what age is she?
15. So she's got a spacer, but I was quite curious when you showed that little pocket one.
Yeah, you can get collapsible spacers.
Yeah, whereas she's got some rather big thing, which then she's not very keen on, but she's
volumatic. Well, a big one this size. Yeah,
so she's running off the pitch. Well, in fact, they're now sticking her in defence because she can't run up and down the wing.
No, right. This is what happens. You know, talking as a grown-up child, it really affects your emotions and you know, emotionally. And this is why I'm so keen. So you can get different devices. You can have a look at them on Right Breathe or Asthma UK, because generally the big volumatics, they tend to give them to younger children and they do have collapsible spacer devices as well that can fit nicely into your backpack or your handbag or whatever. So don't put up with don't put up with one thing. Go and be a customer. Talk to the pharmacist. We don't have any pharmacists on here. I think they're wonderful. But pharmacists will always give you good advice, and as long as they're compatible with an aerosol inhaler, that's the other thing you've got to check. Okay, have we got some more questions? No, I've still got loads, but I'll ask you another time. Thank you so very much. Thank you guys so much for coming, for being participative, asking fantastic questions. Thank you for John. John and I think, are going to continue to work together on various things. Do keep in touch. You've got my email address. You will get the recording. You also will get a copy of the slides. Tell everybody, and we'll see you again.
Yeah. Thanks, everyone.
Bye.
See ya. Bye.